Thank you very much for joining this latest webinar on emerging and re-emerging infections among migrants. I think this is a really interesting topic, full of very important infectious diseases and something of great interest to everyone, I think. My name is David Jenkins. I'm a medical microbiology consultant in Leicester, England, and the treasurer of ISAC. And it's my great pleasure to introduce you to this webinar. We've got two brilliant speakers. But before I introduce the speakers to you, I want to introduce my co-host, Regina Berba. Regina, can you say a few words?
Hi, hello everybody. I'm Dr. Regina Berba. I'm an infectious disease doctor at the Philippine General Hospital in the Philippines. I'm part of the ISAC Executive Committee, and I'm part of the Philippine Society for Microbiology and Infectious Disease, which is a member of the ISAC. Good evening, everybody.
Great, thanks very much, Regina. So I will start off with introducing Dr. Aula Abbara, who I know very well, a wonderful infectious disease physician, very dynamic, really impressive work. And Aula is going to be talking about drug-resistant tuberculosis among refugees and migrants. So I'm not going to say any more because Aula is a much better speaker than me. So over to you, Aula.
Thank you very much, David, for the very kind words. So what I'm going to do is speak about drug-resistant TB among refugees and migrants. And so as David said, I work as a consultant in infectious diseases and an honorary senior clinical lecturer at Imperial College in London. And I'm a commissioner for the Lancet Commission on Conflict, Health and Displacement. And I work part-time for MSF Amsterdam as an infectious diseases and malaria advisor. So in this talk, what I will cover is the scale of forced displacement globally, migration as it relates to drug-resistant TB, and some of the strategies and recommendations which can be put in place to protect this often very vulnerable population. I am going to assume some knowledge around the definitions of drug-resistant TB, but as I continue my talk, I'll highlight some of the key definitions for those who may be less familiar. So just to reorientate ourselves, globally, there are around 281 million international migrants around the world, and this figure is probably growing year on year. One thing I would like to highlight is the number of so-called labour migrants, which is around 169 million of this population, and also the fact that among this population, there are people who are forced from their homes, both inside their country borders, i.e. people who are internally displaced people, but also those who are refugees forced out of their country borders. And so if you look at UNHCR figures between 2014 and 2024, we saw a doubling of the number of people who've been sadly forced from their homes from around almost 60 million to 120 million people. And if you look at the green bar of the figure on the right, you'll see that the majority of these are IDPs or internally displaced people, and they have a number of different vulnerabilities than, for example, you might have if you are a refugee or migrant. Over the course of my talk, I'll be speaking about both refugees and migrants and also highlighting some of the particularities which may affect one group over another. And of course, there are important legal definitions for us to understand, particularly as it relates to how people access care and whether the migration is regular or irregular. The other thing I would like to highlight here is I always find this term of refugees and migrants and perhaps the many other terms that we use to describe people on the move rather imperfect. So through the talk, both for myself and Androulla, I guess in the back of our minds, we need to think about the individual stories and trajectories of each of these people and each of these patients who often may have crossed multiple country borders, and also the different vulnerabilities that some may have and some may not have, but also the intersectional challenges, for example, which may relate to gender, disability, education, language, social status, and then onwards, as it relates to something many infectious diseases, but particularly around TB, which we know has a quite a high social dimension. Over my talk, I'd like to highlight some of the key documents which have important contributions to make in this discourse. So 2 or 3 years ago, the CDC, UNHCR and WHO collaborated to launch an interagency field guide around TB prevention and care among refugees and other populations in different humanitarian settings. This is a very useful and mostly practical guide, which is highly implementable in some of the humanitarian and refugee settings that many of us will work in. It mainly focuses on managerial and organizational aspects of TB interventions and some of the new strategic approaches and providing guidance in innovation for TB prevention and care in these humanitarian settings where the populations may often be, one, very vulnerable, and two, highly mobile. So this is a figure taken from this document, and I won't go into too much detail, but I want you to take away the fact that on a patient journey, they may start in one country. For example, I had a young lad from South Sudan who, after crossing many different countries in the Africa region, then in Europe, ended up in the UK accessing many different health systems at each of these time points with different success at each of these time points. And just to highlight, he was symptomatic with TB symptoms soon after his journey, which obviously resulted in quite a long delay by the time he was diagnosed with us for his TB and was able to commence treatment. Many of the populations in the different countries may be affected by different stresses, and I'll go on to speak about these, remembering that many may be fleeing conflict or persecution, and they may find themselves either in an interim host country or in a third country, accessing different healthcare systems at different time points along these journeys. And so this is taken from the same document, and it highlights that when we look around the world at the highest TB burden countries, there is quite a strong overlap with the main countries that host refugees and asylum seekers. So if you have a look at the top map, you'll see that you've got Brazil here, but also many countries in the Africa region where there's high TB burden, and many of them have high drug-resistant TB burdens. South Asia, Southeast Asia and onwards. And you'll see there's quite an overlap with those countries, particularly in the global south, which I acknowledge is an imperfect term, but it shows here these countries which host high numbers of refugees and asylum seekers. Bearing in mind that many people forced from their homes often end up either as internally displaced people or in countries surrounding them. So, for example, from South Sudan, you might find yourself in Ethiopia, for example, rather than finding your way to Europe or elsewhere. And we see that this figure is mirrored when we discuss IDP. So you can see here in yellow, the main countries in the world that host internally displaced people, so Sudan, Chad, etc., many of them affected by armed conflict. And you see that there's quite an overlap with countries with high burdens of TB. And so what I wanted to highlight here and get you thinking about the different time points in a patient's journey. And what I'd like to highlight here are there are different risk factors at different stages of this journey. So I use this to teach generally about the migration journey and the different risk factors, not just for infectious diseases, but also for non-communicable diseases, impacts on mental health as well. But I've highlighted at the bottom of this screen some of the factors that may influence the diagnosis and reactivation or infection of TB, but particularly drug-resistant TB. So I've put here for pre-departure, during migration, and then destination, the impact of social determinants, for example, living conditions, education, poverty, malnutrition, and other things which are particularly related to TB, but also, remember, related to things such as HIV and diabetes, which, particularly if uncontrolled or undiagnosed, may also influence the trajectory of TB among these patients. So if we look at the pre-departure stage, you'll see that not just social determinants, but also vaccination status, malnutrition, importantly, the epidemiological TB and drug-resistant TB profile in the country of origin obviously has an influence over the course of your life and also your journey, but also the impact, for example, of conflict on a health system or natural disasters on a health system, which may be the driving force of you leaving your home. This can impact TB at the pre-departure stage as it relates to early diagnosis, for example, of latent TB screening. There may be a lack of diagnostics, and we know that in many conflict-affected settings, diagnostics can be quite sparse. I can give you the example of Syria, where we've really struggled to get adequate TB diagnostics in some of the areas most affected by conflict and probably most affected by TB, partly due to sanctions and partly due to costs and other restrictions. There may be insufficient medications through the national TB programme of these countries, where the health system of these countries can often be degraded by the conflict, but also political insecurity and many other factors. And there may also be interruptions. So you may have access to TB treatment at some times if you have a diagnosis, but TB treatment may run out. Very sadly, one of my colleagues from MSF was recently in Darfur in Sudan, where there's active conflict. And he's a paediatrician who spoke incredibly movingly of TB drug interruptions for children, and sadly with loss of life for children affected by TB and such drug interruptions, even in the current world where we should have sufficient TB medications for all patients who need it. So moving to during the migration time, social determinants remain very important. We've seen images of people sadly in tented settlements, even in Europe at the peak of the refugee migration in 2015 and 2016 into Greece and then onwards into Europe, and living in those close quarters with inadequate sanitation, with people mixing from high burden and low burden TB countries, can often lead to spread within these refugee and migrant communities during their journey. And there's also other impacts relating to the travel trajectory. During migration, very sadly, we know that patients may face migrant insensitive or refugee insensitive health systems along the course of their journey, whether due to language, prejudice, political restrictions, statutory restrictions, and many other reasons which may disencourage people from accessing healthcare, or even if they were to access healthcare, may not be able to successfully navigate it for a variety of reasons. Even if they started the journey with TB treatment, they may have interrupted treatment, but they may also have a lack of personal health records, and we'll discuss that in the recommendations shortly. And when patients reach their destination in the host country, even if the host country is in Europe and has a relatively functioning health system, their journey and challenges around TB and diagnosis may not end. They will still be subject in many instances to social determinants with poor housing. They might find themselves in asylum seeker hotels. They may find themselves rapidly moved from an asylum seeker hotel for various reasons. Of course, there's a psychosocial impact. And there may be other factors such as policies, legal status, and other influences which may negatively impact their ability to access healthcare in their host country. And this is particularly so, and remember I spoke of the intersectionality, but also the differences among this refugee and migrant population. So for example, if you're undocumented, or like the young lad I had from South Sudan, can't read or write, your access to healthcare may be even more challenging than a refugee or migrant who doesn't have those challenges. And this can impact things such as screening, active case finding, which is ACF, rapid and unplanned relocations, and also sadly a lack of support. So in the hospital I work at St Mary's in London, we have phenomenal TB nurses who are a great source of support for our patients, but this may not be the case in all areas where both drug-sensitive and drug-resistant TB is managed. And I just wanted to stress here at the pre-departure stage what our patients may be forced to leave. And this may apply both to refugees and migrants. Very sadly, around the world, we're seeing more and more attacks on healthcare. For us in infectious diseases and microbiology, this also means there's a lack of diagnostics. So, for example, in Aleppo Hospital in Syria, we've done a lot of work to support our colleagues building their microbiology laboratory. And I don't have the photo here, but sadly, at the end of 2016, the whole of that hospital and microbiology department was bombed during the course of the conflict, leaving it completely destroyed. So this has major impacts on diagnosis and access to diagnosis in many of these settings. And sadly, despite it being against international humanitarian law, we still continue to see attacks on healthcare in many parts of the world, including the DRC, Ukraine, Syria, Gaza, Myanmar, Yemen, and sadly many other countries. And you'll probably realize that many of them are also very affected by both drug-sensitive and drug-resistant TB. People are also increasingly forced from their home by climate change and natural disasters. So on the left, you'll see here the massive impact of the floods in Pakistan, which forcibly relocated a few million people. Fortunately, the majority were able to go back home, and this is what we call circular migration. But some of the most vulnerable were still not able to return home. And of course, that has major impacts in terms of access to healthcare and access to TB diagnosis. We cannot ignore the interrelation between malnutrition. So this animal is from the Horn of Africa, so Ethiopia, Eritrea, Somalia, where often there is drought and often there is animal die-off, which can lead to malnutrition, but also force people, many of them in rural communities or herders, elsewhere to seek access to food and access to healthcare. And of course, some people may be forced from their homes from wildfires. So this is a photo taken from Brazil, and you'll remember this is one of the high TB burden countries around the world. So just to give an example of a country sadly affected by conflict, but also sadly affected by a high burden of TB, I wanted to bring your attention importantly to Ukraine, which often doesn't get discussed enough, especially given the ongoing conflict and violence that many of our Ukrainian colleagues are facing. So Ukraine has the 4th highest TB incidence in the WHO Euro region, and it's got the 5th highest number of confirmed XDR, so extensively drug-resistant TB worldwide. So just as a reminder, when we say drug-resistant TB, we mean TB which is resistant to rifampicin and isoniazid, and then extensively drug-resistant TB includes resistance to quinolones and another group as well. So these are very difficult to treat and may take many, many months, if not longer, of treatment, and requiring a high fidelity of treatment and monitoring to ensure successful outcomes. So as a reminder, Ukraine has over 7.7 million refugees originating from Ukraine and around 6 million people who are internally displaced given the ongoing violence. What I'd like to do here is read this quote from Askar Yadilbayev, who's the WHO team lead, which appeared in The Lancet in 2022, because it highlights some of the key issues that we need to understand when we talk about refugees, migration, and drug-resistant TB. So to quote him, he says, "War and humanitarian crisis will have a negative impact on TB and drug-resistant TB in Ukraine. Delayed diagnosis of TB and drug-resistant TB will result in delays to initiation of appropriate treatment, eventually leading to poor outcomes, which will be aggravated by undiagnosed and, as a result, untreated TB cases and continuous transmission of infection in communities." So just as a reminder, we need early diagnosis to ensure a reduction in the spread and infectiousness in these vulnerable communities. I'd also like to highlight here an example of good practice, as we've seen in this important collaboration between the Polish and Ukrainian health authorities, the Polish Health Institute, Médecins Sans Frontières, and the WHO. So broadly, when we discuss clinical care of patients around the world, but particularly for refugees and migrants, we must always focus on patient-centered care. And this becomes increasingly important for TB and drug-resistant TB, given the importance of building a relationship with our patients over a long term and ensuring high compliance at the very least for 6 months, but often up to 24 months, if not longer, for certain instances. And so what this collaboration showed was the possibility of supporting Ukrainian colleagues to work in Poland to provide treatment for Ukrainian patients with drug-resistant TB and ensure access to some of the newer TB medications that are needed for successful outcomes. And it also showed that they were able to support many of these patients to be treated at home. And to ensure adherence, they used VOT, so video observed therapy, which is obviously much more convenient for patients who are often traumatized in the course of being forced from their homes due to conflict, but also allowing them to stay with their families and as quoted here from Dr. Mazur, live a regular life with minimal disruption. And of course, this is for patients who are shown to be not infectious in these sorts of situations. But it becomes really important that we're able to provide patients with access to bedaquiline, delaminid, and the other TB treatments, which have a more favorable side effect profile than some of the other medications that are available. So some of you will remember that we used to use an awful lot of amikacin when we treated drug-resistant TB, and of course that has very high side effect profile and requires high levels of monitoring for our patients with drug-resistant TB. And I do think the example from Ukraine really does show us what these collaborations and taking a patient-centered approach to managing TB and drug-resistant TB can provide for our patients. So we must always be looking for these excellent examples of clinical care for these vulnerable patients. So this is taken from the Global TB Report in 2024, just to remind you of the burden of drug-resistant TB that we are facing. So this is for MDR-TB, so multi-drug resistant TB, so TB resistant to rifampicin and isoniazid, but also included within this is rifampicin-resistant TB because of the importance of rifampicin in our TB drug regimens. So looking at this graph down here at the bottom, you'll see that globally, there's about 400,000 cases as of 2023 of drug-resistant TB around the world. And then looking here, so one risk factor and why we must always be careful when we're treating patients with drug-sensitive TB is if we don't have a high fidelity of treatment and we don't work with our patients to ensure that they take their medication as they're meant to, you might end up with drug-resistant TB, which obviously is one of the most significant adverse things that we can have with our patients, particularly if they should be on treatment for their drug-sensitive TB. And so what you'll see here, the percentage of people previously treated for TB has fallen from around 20% who now develop drug-resistant TB, from around 20% in 2015 down to about 15-16% here in 2023. And that's just a reminder that we should be using all means at our disposal in terms of supporting our patients and taking a very patient-centered approach to care for patients to reduce the risk of them either not complying with treatment or running into side effects which may leave them susceptible to developing drug-resistant TB. I'm going to speak a little bit later about screening, and I just wanted to remind you that when we talk about TB, we're talking about a spectrum of disease, right through here from patients in which infection is eliminated, right through to latent infection, through to subclinical disease, and then to active disease. And of course, active disease may be drug sensitive or drug resistant. When we diagnose latent TB infection, obviously we don't have any positive culture. And unless perhaps that we know that they had a significant contact exposure, we won't know at that stage if they have drug sensitive or drug resistant TB, or certainly what they've been exposed to. And also when we look at the reactivation timeline of latent TB, we need to remember that it most often occurs in the first 2 to 5 years following migration. And this may be attributable to poor living conditions and barriers to accessing healthcare services. But the interesting thing is if you look at UK data, UK HSA data, we find that in some instances, more than 50% of cases are diagnosed more than 5 years after entry into the UK in terms of the reactivation of latent TB. And that shows the importance of early screening and early treatment for latent TB to prevent this reactivation. So I wanted to draw your attention to a couple of papers which are well worth a read, which speak more about social determinants of TB. And here they also talk about COVID-19 as well, mainly because among the risk factors for both drug-sensitive and drug-resistant TB are all of these that we have around here, which are things around socioeconomic status, housing, malnutrition, food insecurity, which sadly, now that we're seeing the impact of US aid cuts on the World Food Programme, we may be seeing more and more of, but also the lack of access to services and diagnosis. So, for example, untreated HIV, untreated diabetes, and many other factors which may prevent our patients from accessing appropriate healthcare. And some of you will remember in 2023, and I think we can use different bylines for this, but Sinha and Mehta described this as food, the TB vaccine we already have. And I think there's many other things that we can put instead of food here, for example, around adequate care for our patients, early diagnosis of things around HIV or diabetes or other things which may lead to a reactivation of TB. So in the next couple of slides, I wanted to draw your attention to a couple of papers by an excellent team of authors. So Sally Hargreaves, John Friedel and Laura Nellams have done a lot of work around multi-drug resistant TB and refugees and migrants. So the key point here is they did a systematic review to look at the treatment outcomes for patients who have drug-resistant TB who are migrants or non-migrants. And what I like about this paper is that it highlights some of the treatment challenges with drug-resistant TB, and I haven't spoken about those just yet, so I'm going to highlight them just here. So firstly, I've mentioned that there's a long duration in terms of treatment, even with the Bangladesh regimen, which is 9 months, but for others it may be 20 months or 24 months, taking into the continuation phase, and depending on the site of disease and how resistant the TB that we're treating is. It's typically at least 5 active drugs, or certainly at the beginning, with a high pill burden, high toxicity, high side effects, frequent monitoring, frequent interaction with health services, and often a long hospital stay, particularly for patients who are sputum positive or have other reasons to need to be in hospital for that support. And they often require either DOT or VOT. And they require a long-term dedicated patient support, not just by TB nurses who are often excellent, but also with social services and people to support housing, because I'm always surprised by the number of my patients with multi-drug resistant TB who sadly end up losing their homes or their jobs in the course of their treatment. And what this group found was 15 studies which report on MDR-TB outcomes that among 258 migrants and 174 non-migrants, the adherence was 71%, so the global target is 75%, with no significant difference in the estimated rates of adherence between migrants and non-migrants. And this is another paper by the similar group of authors, which is one that I always go back to for a number of reasons. So this paper looks at multi-drug resistant TB and migration to Europe. And what they find is a number of things, but particularly I'm going to draw your eye to this map. And sorry, I'm just looking at time because I might need to speed up a little bit. You can see quite significant differences between the countries in Europe, in Northern Europe and Western Europe, in terms of the proportion of foreign-born population. So in the dark red, it's more than 15%, but also in the proportion in these countries of the overall foreign-born population in terms of overall TB rates, but also in multi-drug resistant TB rates. And so I'm just going to draw your attention to a couple of points I wanted to make here. So firstly, in low incidence TB countries, so that's defined as less than 20 per 100,000, MDR-TB rates are higher among people who are foreign-born. And then if we look at the whole of the EU, EEA member states, 73% of MDR-TB cases are in migrants, of whom 51.7% originate from the EU. So if you look at Eastern Europe, there's particularly high rates of MDR-TB compared to Western or Northern Europe. I'm going to use the UK as an example here, where migrants comprise 90% of MDR-TB cases, but about 70% of overall TB cases, taking into account drug-sensitive TB. I won't go through the problem list here because I think I've highlighted some of these, but hopefully these slides can be shared and you'll be able to have a look at these with some of the challenges that we face around MDR-TB and migration. But what I like here is how this group have summarized some of the key recommendations, and we'll go on to talk about that a little bit later. So firstly, access to services to ensure early diagnosis and effective follow-up and treatment for migrants continues to be important. And this is highly relevant in the current anti-migrant discourse that we're seeing around the world, but we must all, as healthcare providers dealing with patients with TB and drug-resistant TB, ensure that policies which restrict free access to statutory health services in European countries need to be addressed and challenged, because they present not only a challenge for the patients themselves and the communities, but also barriers to diagnosis and treatment. So from a public health perspective, they may increase the risk of transmission and the acquisition of MDR-TB patients. And I'll go on the later slide to talk about the importance of screening and at what stages we can screen our patients when they enter particularly Europe or any of the other countries which they may choose to migrate to. And despite the efforts in the last few years, there's still a need for research into this area of MDR or drug-resistant TB among refugees and migrants. I'm going to very briefly mention one of the strategies around latent TB screening. So what this looks at is pre-entry screening programs for TB in migrants in low incidence countries. So remember that we define that as about less than 20 per 100,000. So around the world, there are different national approaches in these low TB burden countries, and this may be pre-entry. And some of you will know that this is often compulsory, perhaps as part of a visa application, upon entry or post-entry. However, what they state is that there's weak evidence base on effectiveness, and there's also very heterogeneous political environments and also very different approaches across these countries. However, they state that most low incidence countries have screening in place either for active TB or latent TB infection. So very briefly, I'm just going to comment on what they find. So 15 papers between 1982 and 2010, they found that 3.7 million migrants had underwent pre-entry screening. There was a high heterogeneity, but after the stratification by the country of origin, the heterogeneity was reduced for culture and smear confirmed cases. And it stands to reason that what they found was the yield of culture confirmed cases increased with the prevalence in the country of origin. And they give some estimates based on the pooling of all of these studies. The interesting thing here is the pickup for MDR-TB cases was very low in comparison to the number of screening that occurred. And only 3 studies described MDR-TB. And what they found was 33 cases of 183 cases in this particular cohort of culture confirmed had MDR-TB. So in the next 2 minutes or so, I'm going to speak about the recommendations. Many of these recommendations are taken from this document, which I'd highly urge you, if you're interested in this topic, to read. It's from the WISH Foundation, so the World Innovation Summit for Health, that was presented in Qatar at the end of last year, which focuses on innovative solutions for the elimination of TB among refugees and migrants. And so many of the recommendations are drawn from this document. And so probably the very first and most important is we need high-level leadership to secure political support for addressing TB in migrants, refugees and IDPs. And that's with all the different key stakeholders, civil society, and of course the affected communities themselves. And on the right here, you'll see a very nice collaboration with UNHCR, IOM and others for diagnosing when active case finding of TB among Syrian refugees in Jordan with a mobile chest X-ray unit you'll see down here. Secondly, we need refugee and migrant-sensitive health systems, health policies and legal frameworks to protect the right to healthcare and to facilitate detection, ensure continuity of care, free of stigma and discrimination for refugees and migrants. And we need to ensure that refugees benefit from universal healthcare coverage through the delivery of comprehensive, people-centered services through primary healthcare, while strengthening referral systems to other levels of care. This fourth recommendation is obviously a very important one, but one that I find a little bit problematic, and I'll explain why. So what it speaks about is the need for inter-regional level actions such as cross-border collaboration, regional consilia with sharing of information between countries with digital technologies and e-platforms. And given the amount that people on the move between different countries with TB or at risk of TB traverse, this is obviously very important, but I think for many of us who are concerned in the humanitarian sector about security of these digital platforms and potential risks to our patients, this would need to be done very, very sensitively and very, very securely to ensure that the information doesn't go into the wrong hands. And then lastly, I've put down here some recommendations around detection and case management and access to diagnostics and relevant treatments. And I think this is my penultimate slide. What I put here is some of the commitments and requests at the second UN high-level meeting on TB from 2023, which I think is highly relevant to this conversation. So I've highlighted these first 2 as they relate to refugees, migrants. And so the first point here is around providing comprehensive care to all people with TB. And just as a reminder, we need to think about the intersectional vulnerabilities that patients may have. So this may be people living with HIV, people with TB-associated disabilities, people who are older, people who may be pregnant, and people who may have, and I would expect that many of our refugee and migrant patients may have significant mental health and psychosocial protection needs. And of course, children are a very important part of this because diagnosing and treating TB, particularly drug-resistant TB, is very challenging in children and also highly specialised. And secondly, there's something really important about addressing the crisis of drug-resistant TB here in particular, relating to the availability of testing, the availability of the required treatment regimens, and making sure that we're able to support our patients through monitoring them over the course of their treatment, which of course relies on making sure that our systems are refugee and migrant sensitive, and they have all the support that is required to ensure a high fidelity of treatment and compliance, the early detection of side effects, and all the sort of psychosocial support, as well as the clinical support that they may need. And I'm sorry I've run on a little bit, but the key points I wanted to make today was that refugees and migrants are a heterogeneous group who have different life stories, different risk factors for drug-resistant TB, have different migration journeys and different interactions with health systems. So we must always listen to our patients to really understand all of these factors as they relate to the patient themselves and also TB. The proportion of drug-resistant TB among host and refugee or migrant populations varies between high incidence and low incidence TB countries and migration factors. And the diagnosis of both drug-sensitive and drug-resistant TB detection and management needs stable health systems, access to diagnostics, and patient-centered approaches to ensure that we treat them effectively. And cross-border travel provides challenges, but something that we should be seeking to address as a humanitarian community. And lastly, that we require health policies and systems which are refugee and migrant sensitive to support screening, active case finding, and the early diagnosis of drug-resistant TB. So thank you very much for listening.
Thank you very much, Dr. Aula, for that very excellent and thought-provoking lecture. Okay, let me proceed to the introduction of our next speaker. Professor Androulla is the director of the WHO Global Collaborating Center for Reference and Research on Diphtheria and Streptococcal Infections and consultant of the Public Health Microbiologist at the UK Security Agency. She is a visiting professor to the Faculty of Medicine, Department of Infectious Diseases at the Imperial College, and an adjunct professor at the University of Cyprus Medical School and the European University School of Medicine. So without further ado, let me please introduce to speak to us about diphtheria and other vaccine preventable infections among refugees. Let's welcome Professor Androulla Efstratiou.
Thank you very much for your patience, everybody. So in this presentation today, I'm going to discuss two rather what we classify as ancient diseases that have sadly re-emerged over the last few years. So primarily diphtheria and other vaccine preventable infections in refugees. It's not allowing me to go on to the next slide. Okay, so I think we're all familiar with the priority infectious diseases affecting refugees and other migrants. And as we've heard with our previous speaker, obviously tuberculosis and also other diseases such as malaria, HIV, hepatitis. And more recently, vaccine preventable diseases such as measles, mumps, rubella have emerged. And in particular, two diseases that have always deemed to be very uncommon, diphtheria and polio. And I think the recent flow of migrants into Europe, as we've heard, following the mainly the Mediterranean route from Africa to Italy and the Eastern Mediterranean route, mainly from the Middle East to Greece, has raised fears that the usual patterns of infectious diseases that we observe in Europe will be severely impacted. So what is currently happening in Europe? These are the main routes. So primarily migrants are traveling from places such as the Middle East, Southeast Asia, Pakistan, Afghanistan, into European countries, even islands as small as Cyprus, going across to Greece, and then finally going across into Northern Europe. As we've heard, several million refugees and migrants risk their lives to cross these very treacherous seas. The majority are sadly fleeing conflict in Southeast Asia and also the Middle Eastern regions. And if we look at some data, more than 4,000 people have died while making these very dangerous sea crossings to Europe. This just shows the refugees taking the very, very perilous journeys by sea to Europe. And many of them are landing on Greek islands, such as Lesbos. And this just shows you the living conditions, the tents where the refugees are staying. So, as I said earlier, two very important vaccine preventable diseases have emerged that are causing severe problems. And these are diphtheria and polio. There was an alert issued by WHO in 2022, and this alert indicated the marked increase in the number of cases, in particular of cutaneous or skin diphtheria amongst refugees arriving in the EU and also the Eastern Mediterranean region since January 2022. And this trend is unfortunately still continuing. And many countries in Europe were reporting cases, so Austria, Belgium, France, and so on. And both respiratory and cutaneous cases were identified. Therefore, WHO continues to call for increased awareness and, very importantly, to enhance lab capacity and surveillance. So cutaneous diphtheria reported amongst refugees and asylum seekers, as I said, has been reported by many EU countries. And cutaneous diphtheria is also a potential risk factor for transmission of the disease. Many of the refugees are from endemic countries, and obviously overcrowding, poor living conditions, poor hygiene increases the risk of transmission and also acquiring the disease. And again, I have to stress the limitations in capacity to confirm these infections would obviously delay diagnosis, treatment, and public health interventions in some EU countries. So how should a country respond? I think it's very important to consider all refugees and migrants who lack evidence of vaccination as unprotected, and obviously provide vaccination with appropriate diphtheria toxoid containing vaccines. And again, clinicians in the EU who have probably never even seen a case of diphtheria may lack experience in diagnosis, and they may not consider diphtheria as a differential diagnosis when a patient presents with these non-healing ulcers and also other skin lesions. So increased clinical awareness is really important. And it's also important to alert clinicians in country to the possibility of these infections, particularly those travellers returning from endemic areas. So what I'd like to do today is to focus on these two diseases, particularly in diphtheria, that has posed many problems in every single WHO region. So I'd like to discuss the clinical diagnosis, look at the prevention, control and management, provide some data on the global and EU epidemiology, and discuss a little bit about the microbiological diagnosis. So some basic facts about diphtheria. The main causative organisms are the toxin-producing strains, mainly the human species, which is Corynebacterium diphtheriae. There are two other species that are mainly zoonoses, but they can also produce diphtheria toxin and can cause the clinical disease. The incubation period is normally 2 to 5 days. It can be longer, and the distribution is worldwide. The source is normally the upper respiratory tract, and the spread is usually respiratory transmission, so person-to-person contact with infected secretions. And obviously, vaccination prevents the manifestation of the severe clinical form of the disease. There are case definitions by WHO. These will be described in the document, the WHO standards. So diphtheria is defined as an illness of the upper respiratory tract, characterized by pharyngitis, tonsillitis, etc., with the presence of this very characteristic adherent pseudomembrane. This is a pseudomembrane which is an exudate that is grey, it's very thick, and it very much firmly adheres to the larynx. Some countries can choose to expand their case definition to include mild cases without a pseudomembrane, and also non-healing skin ulcers in a person with a travel history that has been to an endemic area. However, the final case definition is based on the laboratory confirmed case. So a laboratory confirmed case is a person with Corynebacterium diphtheriae isolated by culture and is positive for the very lethal diphtheria toxin production, regardless of symptoms. So this could be a mild case, but not presenting with the classic pseudomembrane. So it's very important for countries to have the capacity to undertake these tests or to be aware of some sort of referral system to a reference lab for toxin testing. So toxigenicity must be confirmed by the phenotypic test, which is called the ELEC test. Many countries are using real-time PCR, which obviously complements surveillance. It provides preliminary results and can qualify as lab confirmed. So for a case to be investigated, basically one clinically confirmed or lab confirmed case should trigger a public health response. 2 cases equals an outbreak, and every single case should be investigated with appropriate samples being collected, prompt treatment with diphtheria antitoxin, antibiotics, immunization, and of course, contact tracing. So a little bit about the disease itself. As I said, there are 2 major forms, respiratory and cutaneous. The respiratory form, symptoms range from mild pharyngitis to very severe invasive disease with the presence of the pseudomembrane. If left untreated, the patient will have complications such as myocarditis, neuritis, thrombocytopenia. The case fatality rate is still quite high, it's about 5 to 10%, but in those younger than 5, it can be as high as 20%. But treatment is available. First-line antibiotics, penicillin or macrolide with the diphtheria antitoxin. So the site of infection, primarily it can involve any new mucous membrane, and the disease is normally classified based on the site of infection. I'd like to now just show you some clinical photos of patients with diphtheria. These are patients from the ongoing outbreaks in Indonesia. So this is a patient showing the very characteristic pseudomembrane. This is a very, very adherent membrane. If you try to remove it, it will cause extensive bleeding. The most appropriate sample to take is ideally underneath the membrane. Again, another photo showing the characteristic exudate. And this is a piece of diphtheritic membrane from one of the toxin-producing species. And this is a patient presenting with what we call bull neck, which is the inflammation of the cervical lymph nodes. And here we have a patient with a tracheostomy. And sadly, here we have a patient, a myocarditis patient. And finally, and very sad, a patient in the terminal stages of the disease where you would observe extensive hemorrhaging in almost all orifices. So clinical diphtheria can be treated, as I said, with prompt, rapid treatment. Cutaneous diphtheria, again, we tend to see these a lot, certainly in recent years amongst migrants and refugees, and also amongst travellers returning from places like the tropics. So these are very characteristic lesions. They're what we call non-healing rolled-edged ulcers with a base covered by this hard grey adherent membrane. They often follow insect bites, and they can be mixed with other organisms such as Staph aureus, group A streptococci. Toxic manifestations are usually uncommon, but they can occur. And cutaneous diphtheria is as infectious as respiratory diphtheria. And here are some photos showing the different forms of respiratory diphtheria. This is the classic rolled edge ulcer with this base covered by the hard membrane. Here we have a non-inflammatory wound on a toe showing the ulceration, and here we have a circular ulcer on the ankle. This is the characteristic rolled edge ulcer. It looks something like a volcano, a crater from a volcano, actually. They're quite difficult to treat. They can take days or even months to heal. So diphtheria can be prevented. Vaccination, of course, and prompt clinical recognition. Diphtheria antitoxin with antibiotics. It's very important, although not possible, to try to reduce overcrowding and improve living conditions in endemic areas. And as I said earlier, effective surveillance is really important, so both epidemiological and microbiological surveillance. Diphtheria antitoxin is the main form of treatment. The DAT used to be made by many, many countries, and unfortunately now it's down to a few countries. It is available. However, there does need to be a global stockpile, and it is a good idea for countries to have even a small stockpile within their country. These are the WHO recommendations for vaccination. So basically routine programs, 3 primary doses along with booster doses. And in non-routine settings, such as in migrant camps and so on, it really depends on the age of the patient and the previous immunizations. And with these, with migrants and refugees, most of the time records are not available. So they should be treated as unimmunized. So surveillance, again, I have to stress, is extremely critical for diphtheria for many reasons: to understand the epidemiology, to monitor the trends in disease, and to identify outbreaks promptly and inform response. And very importantly, to evaluate the efficacy of a vaccine program and to inform public health planning and vaccination policy. And again, I'm going to keep saying this, both microbiological and epidemiological surveillance are important and must work together for surveillance to be efficient. I'd like to now show you some data from WHO. This is the latest data showing the number of cases between 1980 and 2023. So these are the number of diphtheria cases. This huge peak here. Sorry, my mouse is. This shows the peak which occurred in the mid-1990s in the former Soviet Union, where basically it was the breakdown of the former Soviet Union. And at the peak of the epidemic, there were more than 50,000 cases. And I believe this was probably the largest outbreak of diphtheria in the history of the disease. If we look at the different regions of WHO more closely between 2018 and 2023, if we look at the green line here, This indicates the WHO Africa region, where the number of cases are increasing quite dramatically, almost monthly. The other regions to look out for primarily are the Southeast Asia region, particularly in India, Pakistan, Afghanistan, and also the Eastern Mediterranean region. This shows the top 10 countries reporting diphtheria. So, as I said, Nigeria and India have many, many cases. If we now look at the number of cases reported amongst migrants and asylum seekers, this is data from 2023. More than 400 cases of diphtheria were reported to WHO amongst migrants. Most of the migrants were male with a median age of 17 years, and there were sadly 8 diphtheria-related deaths. The main countries of origin were from endemic regions such as Afghanistan, Syria, and Nigeria. And this just lists the number of diphtheria outbreaks that we've seen between 2017 and 2024. So basically, what I'm saying is that diphtheria is present in every single WHO region. There is guidance from WHO. There are the surveillance standards that were published in 2018. And there is the laboratory manual for lab diagnosis published in 2021. And more recently, a document was published on lab testing for diphtheria in outbreak settings. And again, last year, there is a document on clinical management of diphtheria. And all these documents are available on the WHO website. Okay, so if you have a case, very important to collect samples, as I said, and to collect the appropriate data for surveillance purposes. This is the algorithm for lab diagnosis of diphtheria, which is in the WHO manual. So most labs have the capability to undertake the primary culture, and it is highly recommended to send any suspect organisms to a reference lab, either within your country or to one of the 2 WHO reference labs, either to the UK or to the other reference lab, which is based in Munich. This is the organism on blood agar, very characteristic colonies. And as I said, the key test in diphtheria diagnostics is the ELEC test. This is a test that is rarely undertaken in routine labs, and it's only undertaken by a few reference labs worldwide. Therefore, a lot of labs have lost their skills in many countries. As I said earlier, all UK labs usually refer suspects isolates to our collaborating centre. So it's very important to retain skills in this very specialised field of microbiology. This is the modified ELEC test using the specialised ELEC medium. It's rather like an immunoprecipitation test. So we have control strains, positive and negative controls, and 2 test strains here. So if the test strain is positive, it will form a line of identity with the control strains, but not with the negative control, obviously. It's easy to read, and the test result is usually available within 18 hours. There are novel diagnostic assays. Many labs are using real-time PCR for rapid species confirmation and also detection of the diphtheria toxin gene. But it's important for a lab case, for a case to be confirmed by the phenotypic test. There are novel tests being developed. There is a lateral flow test currently being revived and developed. And there are also other new molecular innovations under development. This is the very promising ICS strip. So just shows you this is a non-inoculated strip. This is a negative test with a positive control. And this is a test that is positive for diphtheria toxin. It's a very rapid test, usually results within 8 to 10 hours. So it's a lot more rapid than the ELEC test. But as I say, it is still under development. In terms of outbreaks, molecular typing can be undertaken, normally MLST, and there is a database hosted by the Institut Pasteur. And it's important to submit isolate information to the database. We also, in terms of capacity building, in terms of lab diagnostics, as a collaborating centre, we are commissioned to undertake laboratory workshops worldwide. And we've certainly held many workshops over the last 2 decades. This is one workshop which was held recently in the Eastern Mediterranean region. So with diphtheria, as with other diseases, there are major challenges. It is still deemed to be uncommon, particularly in countries with good immunization programs. And so it's difficult to try and maintain expertise in clinicians, microbiologists, and public health officials. So I think the greatest challenges are retaining and developing these skills, trying to increase clinical awareness and building good surveillance systems. And I think the recent resurgence of diphtheria amongst migrants and asylum seekers, and the fact that cases and epidemics are being reported from every single WHO region, tells us we must be prepared. So my take-home message for diphtheria is consider diphtheria, because without testing, it won't be diagnosed. And think risk factors: overseas travel, migrants, lack of immunization. And again, early public health measures are absolutely crucial. Do not wait for confirmation if there is a probable case. And again, very important to ensure there is a stockpile of diphtheria antitoxin in your country. Okay, so that was diphtheria. I'd like to now just give you a brief overview of the other disease which has sadly re-emerged, and this is polio. So I think we're all familiar with what is polio disease. It's quite an infectious disease that mainly affects children under 5. It's transmitted by person to person, mainly through the fecal oral route, or less frequently by a common vehicle such as contaminated water or sewage systems. Most infected people have no symptoms or mild symptoms, but 1 in 200 infections does lead to permanent paralysis and even death. So polio can be detected in specimens from the throat, feces, and occasionally CSF. And you can diagnose the virus by isolating the virus in cell culture. Most labs tend to detect the virus using molecular methods, PCR, sequencing, and serology. 3 types of polioviruses. There are 3 types of wild poliovirus, WPV. Type 1 is the only type that is in circulation today. Type 2 was eliminated in 1999. However, there is now a circulating variant poliovirus type 2. This was isolated recently from sewage systems in the Ukraine, Europe, and also the US. Type 3, I believe the last case was reported in 2012. So just a little bit about polio epidemiology. We know that wild poliovirus cases have decreased by over 99% since 1988, where there were an estimated 350,000 cases in more than 125 epidemic countries, to 190 reported cases in 2024. And as of 2024, endemic wild poliovirus type 1 and the circulating vaccine-derived type 2 poliovirus still remain. And more recently, cases have been identified in the Middle East, particularly in Gaza. So this just lists the main outbreak regions or recently reported cases. So mainly cases in Africa, from sewage samples, as I said, in Americas, Canada, US, from the Eastern Mediterranean, and also more recently in Europe, from Israel, Ukraine, and Southeast Asia. So there is really still a threat of polio in the European region. In 2024, several countries in Europe did report poliovirus detections in environmental samples. For example, last year in September, Spain reported that it detected a vaccine-derived poliovirus which emerged in northern Nigeria. All the detections were investigated, and unfortunately, no cases of paralysis were reported. Cases also reported in conflict zones, which pose a major threat to vaccine coverage. And so again, WHO have issued this very, very frightening statement that the recent return of about 600,000 undocumented migrants from Pakistan to Afghanistan and an estimated 200,000 unvaccinated children in southern Afghan regions are a threat to regional gains against polio. I'd like to now bring to your attention the Global Polio Eradication Initiative, which is a huge public-private partnership that is led by national governments with 6 key partners, including WHO, Bill and Melinda Gates, and so on. And its major goal is to eradicate polio worldwide, and particularly focus on 2 countries, mainly Pakistan. So basically, they are focusing on every missed child in Pakistan, ensuring even the most vulnerable communities are served with vaccination services. So strengthening surveillance and so on. And also in Afghanistan, they're focusing on reaching out to every single child in Afghanistan with vaccines. This is just a summary of new polioviruses. This is a summary which is published every week on the polio eradication website. So isolations have been seen in Pakistan, mainly environmental samples. Chad actually had 3 CVD-PV2 cases, along with environmental samples. A case in the Congo and 3 cases in Nigeria. So if we look a little bit more closely to home, looking at poliovirus in Europe, the circulating vaccine-derived poliovirus type 2, as I said, was detected in sewage systems recently in 5 European countries, mainly Spain, Poland, Germany, UK, and Finland. And when analysed, there was wide genetic variation amongst the samples between and within the countries, and even within the sampling sites. So this suggested that there had been multiple independent importations, almost simultaneously from outside the European poliovirus surveillance networks. All 5 countries maintained high immunisation coverage, with 3 doses of IPV. However, subnational coverage of the 3rd dose of polio vaccine in 2023 actually ranged between 43% and 99%. And I think this finding means populations are still chronically under-vaccinated and they are vulnerable to polio. If we look at Gaza, the threat of polio is still present in Gaza. Several cases have been confirmed, others are suspected, and the virus has also been detected in wastewater in 6 different locations. However, there's been a huge increase of dosage of polio vaccines into Gaza. UN has bought, I believe, more than 1.6 million doses of vaccine. And mass immunization, I believe, started at the end of August last year, and this still continues. And the main goal is to immunize more than 600,000 children under the age of 10. However, there is still concern, and the concern is a risk for spillover into neighbouring countries. So we have two types of vaccines, the oral polio vaccine and the inactivated polio vaccine. Both are needed to fully eradicate polio. However, IPV is much safer and carries no risk of paralysis. So the travel advice from WHO recommends that all travellers to polio-affected areas must be fully vaccinated against polio. Residents and also visitors for more than 4 weeks from endemic areas should receive an additional dose of OPV or IPV within 4 weeks to 12 months of travel. So just to summarise, polio, we know, is a highly contagious viral disease. It can spread rapidly, causing permanent paralysis. 3 types of wild poliovirus, but only type 1 remains in circulation. And more recently, the circulating vaccine-derived poliovirus type 2 has been detected in sewage systems in several European countries. OPV vaccine is inexpensive and effective, but carries a risk of paralysis. Therefore, IPV is being introduced to provide protection against all 3 serotypes, whilst OPV is being phased out to try and make the world polio-free. So the take-home message for polio: there is no cure for polio. It can only be prevented by immunization, and it can protect a child for life. And statistics show that more than 20 million people can walk today who would otherwise have been paralyzed since 1988, when the Global Polio Eradication Initiative was launched. And I heard more recently that the government of Dubai has now provided funds to GPEI, I believe something like $500 million. The treatments for polio focus on limiting and alleviating symptoms. Therefore, vaccination is crucial in the fight against polio. But endemic transmission is continuing, particularly in countries like Afghanistan and Pakistan. And the frightening thing is that failure to stop polio in these last remaining areas could result in as many as 200,000 new cases every year within 10 years all over the world. And that is why it's critical to ensure polio is eradicated completely once and for all. Okay, I'd like to just acknowledge some colleagues, my colleagues in Indonesia, for providing the clinical slides for diphtheria, and also my colleague, Dr. Muscat at WHO Euro, for the diphtheria data slides. Thank you very much.
Many thanks, Androulla, and also to Aula for 2 really fascinating and really important presentations. We've only got a few minutes left for questions, but so let me kick off with first of all a question to Aula. Given the challenges of healthcare infrastructure, funding constraints, and the high mobility of migrant populations in resource-limited settings, what innovative approaches can be used to integrate genomic sequencing and molecular diagnostics into routine screening and surveillance for drug-resistant TB? How can we ensure cost-effectiveness, rapid turnaround time, and accessibility of these technologies, particularly where migrants may have limited healthcare access? So I think this is about bringing the best to everyone in the world, I suppose.
Yeah, so thank you very much, Vikadu, for a really important question. And I have to say, we're very privileged in the UK because we have whole genome sequencing, which has made a massive difference to us as clinicians in terms of understanding, one, more rapidly, whether we're dealing with drug-sensitive or drug-resistant TB, but also secondly, looking at linkages between different cases and different pathways. I think this goes back to some of the key recommendations that came from the WISH TB document, but also the UN high-level meeting, really around high-level political will and investment from all the different key stakeholders to ensure that all our patients have the very best in terms of diagnostics. And that does include whole genome sequencing and some of the molecular diagnostics that you're talking about, but also perhaps even at an earlier level, making sure all our patients have access to the Cepheid PCR machine, which will also indicate very early on around rifampicin resistance and possibly isoniazid resistance, depending on the assay that you're using. The other part of this will always relate to making sure that we invest in resilient health systems around the world. And more importantly, and perhaps I didn't speak about this in my talk, I'm always an advocate of integrating refugees and migrants into existing health systems. So not having parallel health systems, as we know does exist in many of the refugee and migrant hosting countries. So that will become the other side of it, because I always say once you strengthen your health system to be able to be resilient to dealing with refugees and migrants, you'll also benefit your own population as well when it comes to taking the example of TB, the diagnosis and rapid turnarounds that are needed in these situations to prevent transmission.
To Androulla, there's a question here. Are the polio detections in sewage that you mentioned that are from the vaccine strains evidence of reactivation, or is it just from people who had been vaccinated and are excreting the virulent virus?
Good question. I'm not a polio expert, but I believe it could be a bit of both. I really can't really answer that. I think it's many different factors. I think it's probably a combination of both. I don't have any evidence at the moment. So that's an interesting question. I might pose it to the polio experts here at UKHSA.
Right. Okay. Well, Androulla, there was just another question for you then. The question was, how would one distinguish between diphtheria ulcers from cutaneous tuberculosis and Mycobacterium ulcerans? I guess some of the these geographical areas overlap in these cases, don't they?
Yeah, I'm not familiar with the presentation caused by Mycobacterium ulcerans. I'm assuming that they are quite similar. I really don't know. The diphtheria ulcers are extremely characteristic. And one way would be to take samples. This is something that is not done in many countries. If a patient presents with non-healing ulcers, it's advisable to take a sample to exclude, the presence of diphtheria or other agents. So I think sampling, microbiological confirmation is extremely important.
And Aula, a question to you, following on from that first question about TB. Yeah? In some countries, potentially the healthcare given to migrants of one sort or another potentially is greater or better than that to the resident population. How do you feel about that? Is that a true statement or?
So I'm a strong believer in understanding the local context, and we really need to take contextualized approaches to comments like this. And so in some instances, I can say, actually, it is the case in some of the humanitarian contexts and with some of the humanitarian organizations I work with, because their remit is to work with vulnerable people, some of whom may be refugees or migrants, there may be more investment in this. And I don't want to draw attention by giving different examples. However, there's also some superb examples from the EU and from ECHO, from Médecins Sans Frontières, and many other organizations, SAMS, the Syrian American Medical Society, also being another, where they actively don't only provide healthcare for refugees and migrants, but also make sure that that is open to host populations as well. So I think the way to tackle that is to make sure that we're being holistic, and anyone who's vulnerable is able to access the healthcare that is required. And the same goes for vaccination campaigns, as we saw during the COVID-19 pandemic, and the same goes for diagnosis around TB and other infectious diseases.
Yeah, so ensuring equitable resources for the management of TB, regardless of refugee status or resident status, and doing that internationally so that it is seamless across national borders seems like the way forward. Does that exist currently at all, or is that something to be done?
I think that's something to be built on because as I think it was one of our colleagues, I think Fikadu one of our other colleagues mentioned, there is still stigma around TB, particularly drug-resistant TB, also stigma around diphtheria, also stigma around HIV. And generally being a refugee or a migrant can also come with stigma. So I think globally, once we start to address the stigma related to all of these different things, will be one step forward. In answer to your question specifically around TB, it does exist to an extent. So if you look at the Lebanese Ministry of Public Health, they've done a lot of good work supporting Syrian refugees in Lebanon who are at risk of TB and had TB diagnosed, including drug-resistant TB, but also invested in the same for often marginalized migrant populations in Lebanon, but also Lebanese populations themselves. So it exists in some parts, but we can certainly build on it a lot more than we currently have as a global community.
And thank you very much. And then just one final question, I think, because we're running out of time, to Androulla. How did the breakdown of the Soviet Union cause a massive spike in diphtheria?
Okay, so many different factors, which obviously includes, I think, primarily a very large population of susceptible adults, decreased childhood immunization, which obviously has compromised a very well-established childhood vaccination program. And also the socioeconomic conditions, the breakup, the movement of populations. There were, people moving from, there were, I can't remember how many newly independent states. So there was rapid movement from within 15 countries. So all these factors contributed to the Russian epidemic, which started off fairly slowly, but obviously peaked in the mid-1990s.
I think it was very fascinating seeing a lot of the questions. They didn't specifically mention the disease. I know looking at them, and it could have been either TB, diphtheria, or polio, actually. There's some applicable. It's very similar factors involved in the epidemiology and the spread of these diseases. I'm afraid we've run out of time now. And it's a great shame because I think we could have carried on for a lot longer. But I'm very grateful to both speakers, to Androulla and to Aula, for their presentations today. Just to mention to the audience, you'll be able to see both presentations. Again, we'll be putting them onto the ISAC website very shortly. And it's an opportunity for you to review them and also to refer these presentations to your colleagues for their education and training as well. So thank you very much to both speakers and to the audience for the questions, and to Regina for her involvement in this. And it's goodbye from me. And Regina, do you want the last word?
I'd like to thank both speakers for your excellent presentations and all our guests tonight for the audience and your questions that you typed into the chat box. Thank you very much.